هنتكلم عن lumbar sympathectomy. It's one of the techniques we have to know properly in order to give a chance للpatients who are suffering from many medical disorders وخاصة chronic pain disorders. احنا هنتكلم عن lumbar sympathectomy. Previously كنا بنعمله in a chemical way, then came the radiofrequency era, which is adding more advantage in reducing the complications and improving the safety and improving the outcome. But sometimes when we do a lumbar sympathectomy for a patient that needs a lumbar sympathectomy in the form of radiofrequency, sometimes the outcome was not fruitful as before, as with the chemical. At the same time, when we use the chemical, sometimes we can run in some of the complications and the drawbacks of putting a chemical solution that's going to do a denervation. And this chemical solution can harm more than giving the advantages. So we are on a balance, which to use, the chemical or the radiofrequency. And this is what we are going to explain. Now, in our agenda, the introduction and the history of sympathetic block, the indication, the technique, radiofrequency versus chemical, and if there is an evidence. Well, the introduction will start by the lumbar sympathetic block is one of the most common procedures that we all perform in managing sympathetic mediated pain problems for the abdomen and for the lower extremities. And I have to repeat that we are dealing with the sympathetic mediated pain. First of all, if you have a patient who have a disease which you think that the sympathetic nervous system is involved in this problem, you will not be able to tell if this patient has an SMP, which is the sympathetic mediated pain, or it is an sympathetic independent pain, which we call it the SIP. Because most of both patients will be having the same clinical picture. For example, if the patient is having a complex regional pain syndrome, you will not be able to tell that this patient is a sympathetic mediated pain or sympathetic independent pain until you perform the procedure by giving a sympathetic block. For that, most of the patients are symmetrical. Both of the patients will be having the same symptoms. Both patients will have the same clinical picture. So the sympathetic block is also a diagnostic. That's what we mean by a diagnostic block, which is either a sympathetic mediated pain or sympathetic independent pain. People who will improve after the sympathetic block definitely will be categorized as a sympathetic mediated pain. While the patients who will not have a good outcome with the sympathetic block, we will term them as a sympathetic dependent pain. Also, the sympathetic block is also a prognostic. We all know that the sympathetic block can lead to a cardiovascular insufficiencies sometimes in some of the patients. So you will be able to tell which patient will be having potential side effects of the sympathetic block. So it will be a prognostic block. And the therapeutic indications, it varies. And there is a lot of chronic conditions that can be solved or reduced the pain by the sympathetic block. From the history, we'll start by in 1864, where Mitchell were the first to describe the sympathetic related complex symptoms. And they had a good prognostic value, and they had a good observational value when they said that people who had an injury in one of the limbs could have a good outcome if the sympathetic system is involved in this pain. And this was in 1864. In 1901, the reflex bone atrophy following inflammation was described, and they termed that as a CRPS type 1, and there was no nerve injury. So in the absence of nerve injury in 1901, people who were doing studies on the chronic pain that happens after a limb injury, they defined it to be a post-inflammatory injury. And this was a CRPS type 1, and because there was no nerve injury. And from that time, we categorized nerve injury versus no nerve injury. If there is nerve injury, the CRPS was termed as type 2. When it is no nerve injury, CRPS was termed as type 1. In 1905, Capus had the first lumbar sympathetic block done for patients who anticipated that these patients are sympathetic mediated pain suffering from complex regional pain syndrome. In 1924, the first neurolysis by Royle and he used phenol, not alcohol. In 1950, Bonica termed that this complex regional pain, this reflex sympathetic dystrophy is a category of pain that happens in soldiers in the World War II. And this what happened when patients or soldiers were injured by white weapons, let's say by knife or by blades. And these patients suffer from a chronic pain in the limb that's been injured after the disappearance of the trauma. In 1985, this was the era of a single L3 phenol neurolysis. In 1986, the terminology changed into a complex regional pain syndrome, type 1 and type 2. And in 1993, Robert hypothesized sympathetically mediated pain. In 2001, Slaughter introduced the use of radiofrequency in the sympathetic block. Well, the pathophysiology, post-traumatic inflammation and complex immune response is behind the pathophysiology of this complex regional pain syndrome. Central reorganization of neural plasticity in the central nervous system also is behind the pathophysiology of these. A reflex inhibition of movements is mediated by expectation of pain. This was one of the problems that happen with patients having a CRPS. The patients who have CRPS will get what we call kinesiophobia. So they have a phobia from any motion. And this reflex inhibition in the movements is mediated by their expectation that pain is happening when they move, so they stop moving. Reflex sympathetic dystrophy. This is the terminology which was used before. So it is a reflex that happens following trauma, and the sympathetic overactivity takes place. And in the end, reduction in the blood supply to the nerves, to the bone, to the skin, and to the connective tissue can lead to dystrophy. Another pathophysiology is the psychological disorder that happens leading to depression and anxiety. So this is the pathophysiology of a complex regional pain syndrome. Amazingly, that CRPS is running in families, and strikingly, it's associated with patients who are suffering from migraine. So they found that it could be a genetic disorder that can take place. But unfortunately, there is no biomarkers can define a patient that he is prone to CRPS. In the same time, patients with the CRPS will get a release of calcitonin gene-related peptide and substance P, and this is released in leading to a neurogenic inflammation. The complex regional pain syndrome patients, when they have a fund or increase of flooding of the calcitonin gene-related peptide, this will enhance the sweating in the limb. When there is an increase in the substance P, there will be a hair growth disorder, either reduction or overproduction. Patients with the complex regional pain syndrome or sympathetic reflex dystrophy or reflex sympathetic dystrophy has been termed previously, they might get a help by doing a sympathetic block as a diagnostic and a prognostic in the same time. But the lumbar sympathetic block is also used in other conditions other than complex regional pain syndrome. Let's say this is one of the patients who have a sympathetic overstimulation in the limb, and you can see that this edematous limb on the left side is the diseased one, not the shrunken one on the right side. So this was a patient who is suffering from complex regional pain syndrome in the lower limb, and he's having an allodynia, hyperesthesia, and severe pain on walking. Also, one of the indications is patients who suffer from phantom limb, patients with chronic pelvic inflammatory disease, like patients with chronic cystitis and interstitial cystitis and inflammatory bladder, patients with Berger's disease and patients with Raynaud's disease that's leading to a vascular insufficiency. Sometimes in a spinal canal stenosis and narrowing of the spinal canal can also have this problem. Also, hyperhidrosis is one of the conditions that leads to this phenomena and can be helped by this lumbar sympathetic block. Patients with lower limb bone cancers like osteosarcomas. So let's start by talking about the anatomy of the lumbar sympathetic block. Well, the lumbar sympathetic chain is an extraperitoneal, and it's running on the anterolateral aspect of the vertebral body on the lumbar vertebra. And they are running along the medial border of the psoas muscle. So as you can see here, this is the lumbar sympathetic chain, which is running all over the intervertebral. This is the intervertebral disc. This is the intervertebral disc. This is the vertebra, and this is the vertebra. And as you can see here, this is the psoas muscle, the flesh. This is the psoas muscle, and this is the ganglion. And this is the lumbar sympathetic chain joining one ganglion with the other. Well, there is a variability in the position of the lumbar sympathetic chain and the ganglions as well. Well, they found that it could be between 2 to 5 sympathetic ganglions, but the average, they are 3. And that's what we all know, that they are 3. And they are running between the 2nd and the 4th lumbar vertebra. Rarely at L1 we can find one, and sometimes we can find one at L5 also. They are single, or in some situations they can be fused together. The conditions of the lumbar sympathetic innervation varies among patients and from side to side also. So sometimes when we do the block for one side and doing a block on the other side after 3 weeks to 4 weeks, you will find that the response on one side was different from the other side. And this could be from the variability and the diversity of the position of the sympathetic ganglions. L2 ganglion is connected to the 4 lumbar nerves, while the lower ganglions are only connected to a single lumbar nerve. So as you can see here, that this L2 lumbar ganglion, it has receiving a connection from many nerves, from L3, L2, and L1, and sometimes from L4. While each sympathetic ganglion from L3, L4, and L5, they are only receiving the single innervation from the nerve root. L2 ganglion is located at the junction between the upper 2/3 and the lower 1/3 of the vertebral body on the anterolateral aspect of the vertebral body, just anterior to the border of the psoas muscle. L3 ganglion is located at the junction of the upper 1/3 and the lower 2/3. L4 ganglion is variable in position. The psoas border varies posteriorly also, and this could also have an importance while putting the needle in the area of interest while doing the block, because the psoas muscle can reduce the spread of the local anesthetic and can harbor also the neurolytic if it is injected without putting a contrast to know that you are outside the psoas. So it's one of the most important things to make sure that your needle is running on the anterior border of the psoas, not inside the psoas, especially if you're doing a radiofrequency and if you're doing a chemical neurolytics. And necessary to perform the block at various distance from the anterior border of the vertebral body and outside the psoas. This is a crucial. This diagram is showing how أنا شايف في حد كاتب مفيش صوت. هو دكتور علي عيسى الصوت مش واضح؟
لا الصوت واضح طبعا. مفيش أي
تمام
مشكلة في
ماشي
الصوت.
أوكي تمام يا فندم أوكي. This diagram is showing how much a diversity can be found in many patients. So you can find in diagram A, the situation of the lumbar ganglion is different from diagram B, diagram C, diagram D, diagram E, until the end. And this was captured from the Atlas of Anatomy, which was done on a cadaveric patients to show that there were a diversity in the position of the sympathetic ganglion. And this can also give you a clue why the sympathetic block sometimes may be successful and might not be very successful in some situations. It's not the physician himself, but it's the position of the ganglions itself. It's different and variable. So the least variable in position, as you can see here, that L3 ganglion, the lumbar 3 sympathetic ganglion, is always located at mostly in the same position, which is the junction between the upper 1/3 and the lower 2/3. And this, if you have a doubt about the position of the lumbar sympathetic ganglion, if you have a patient that had a block several times and didn't succeed. So if you would like to repeat the block to make sure that this block was done properly and you're worried about the position of L2 and L4 ganglion, do a single L3 block with a local anesthetic, with a good amount of local anesthetic, because this L3 is the least in variability in the position. So it is the key for success if you have a doubt of failed block previously. But the key level for, according to Slaughter, the key level to do a sympathetic block to start with is L2, because this is the key level for sympathetic chain, as it receives presynaptic fibers from many lumbar roots. Well, the technique, here will, first you will have to put the squaring of the vertebral body. And as we can see here, that this is L2. Square the vertebral body on an AP view, put the C-arm on an AP view, and try to square the vertebral body. Squaring means that the upper end plate is flat. There is no double vision, or no double shadow. And the lower border is also, there is no double shadow. So you don't have two borders, a single border. If you can't do this, this is the squaring. And the spinous process in the middle. Next step is you rotate the C-arm in an ipsilateral way to the direction to be blocked. And this will be continued until your transverse process is disappearing behind the anterolateral aspect of the vertebral body, or the lateral border of the vertebral body. This is the area of interest, and this is the starting point, and this is the entry point for your needle. And this, as you can see here, the transverse process has been disappeared after the behind the lateral border of the lumbar vertebra. This is the entry point. Put a local anesthetic, lidocaine 1%. Direct the needle toward the L1 until the lumbar border, until you hit the bone, and then try to escape your needle away from the bone and just be flush as much as you can with the bone. Bone is always our friend during the blocks. Once you reach to the anterolateral aspect of the vertebral body, we put just 0.5 ml to 1 ml of contrast to make sure that you're outside the soleus muscle and you are not inside a blood vessel, and there is no backward flow into the intervertebral foramen. For best results, local anesthetic and neurolytic are performed in L2, and L3 will be sufficiently to have the block. While if you would like to have a good results in doing the radiofrequency lesion, you've got to do it at L2 and L3 and L4. For using the chemical neurolysis, we use phenol. Phenol, as you can see here in the picture, it's crystals. It is going to be prepared with a pharmaceutical company or in the pharmacy. They have a lot of pharmacies that are doing phenol crystals and turning them into a liquid. And following a successful short-lived diagnostic block with a local anesthetic, you can post the patient for another procedure, which is a neurolysis or lumbar sympathectomies. You have to make sure before you do the chemical neurolysis that you have a tight linear contrast spread on the anterolateral aspect of the vertebral body, or you are outside the psoas muscle and not inside the blood vessel, and there is no backflow into the vertebral foramen. We do the chemical neurolysis either at L2, L3, L4 at the vertebral body, and make sure that there is no psoas spread. Mild cranial and caudal spread at the site of the injection is fine. Phenol 6% at 2 ml at each level is very sufficient. Don't go more than this. This is very sufficient. And if you are from the group that would like to do a single needle, as we mentioned before, that there was Royley, he did the first single block by using a single needle at L3, and he did it with neurolysis, no more than 6 ml to be used. And before you take the needle out, flush the needle with normal saline or with lidocaine. to make sure you don't have a fistulous tract, as phenol can cause fistulous tract. Well, some of the clinical peers you have to know before doing the block is when you do a chemical block, the volume counts in success. So small volume will give you an unsuccessful block. A high volume will give you adverse effects. So use what we mentioned, 2 ml is sufficient in each level. Precision of the needle and the position of the needle in this situation is less important if it is up or down between the upper border and the lower border. Few millimeters or few centimeters will not make that much difference because you're not doing a lesion with a radiofrequency, you are putting a local anesthetic. Make sure that you're outside the psoas muscle. Phenol can have an IV absorption, the patient might have temporary blindness and temporary tinnitus, and this disappears by time in a matter of 3 to 4 hours. Ureteric strictures can happen because of the spread of the local and the chemicals over the ureter. Alcohol, if used, can have a devastating thromboembolic phenomena, so we have to make sure that we are injecting outside the blood vessel. 1 to 2 weeks post-sympathetic neurolysis, we might get neuralgia, and this neuralgia will disappear by time if you have a chance to put a local anesthetic and steroids after the neurolysis. This might reduce the neuralgia. Neurolysis at L3 vertebral level can lead to some pain and dysesthesia at the knee. At L2, you can get a genitofemoral neuralgia, and it happens in 5 to 10% of the patients. What we have mentioned that when you put the contrast, you make sure that nothing is spreading backward to the intervertebral foramen, despite the fact that we are in front of the psoas and we are at the anterolateral aspect of the vertebral body, but sometimes this might happen. So make sure that your contrast is not flowing back to the intervertebral foramen, as your urolytic can lead to a paraplegia. Now we come to the radiofrequency sympathectomies. When we started to talk about radiofrequency sympathectomy was because of the devastating sometimes outcome that happens with the patients who receive this chemical neurolysis. So the percutaneous radiofrequency lumbar sympathectomy technique has been reviewed and been advocated by a lot of the pain physicians all over the world. And this was one of the studies that been shown to have a good outcome. And I wanted to mention this. They used a 5 millimeter active tip radiofrequency needle. And they did 2 lesions at each site, and the same sites. We are talking about L2 and L3 and L4, the same position, using 3 needles. I know that putting 3 needles sometimes might be a little bit of a money consuming, because the needle costs and the presence of 3 needles in the same time simultaneously can cost somehow to the practitioner, and you need a radiofrequency device that having 3 outputs. But this has been mentioned that it's the best technique and the best outcome to get, because you need to stimulate each one at the same time, at a separate time, in order to make a stimulation at L2 separately, L3 separately, L4 separately, before you do the neurolysis at a single level, and then you withdraw the needle. And when you withdraw the needle, before you withdraw the needle, we said that we're going to flush with a local anesthetic and saline and dexamethasone. If this is going to spread to the next level, you might not get the proper response from the patient while doing the stimulation if you use a single needle. So their term was using 3 needles simultaneously in the same site. Radiofrequency requires a very precise technique. So you've got to put the needle properly, stimulate the patient without having too much sedation. The patient should be awake. Comprehension with the patient, okay? The rapport with the patient in such situation, that is very crucial. The good thing about it, it's less in side effects. So you don't have the chance of paraplegia, you don't have the chance of ureteric adhesions or the thromboembolic manifestations of the alcohol if you use a high volume. Confirmation by stimulation before the lesioning is very crucial. And here it's very important that when you do it for the lumbar area, you're not going to ask the patient while the stimulation if you feel something in your leg. So the sympathetic stimulation at the lumbar area, the patient's going to experience just discomfort in the abdomen or in the kidneys. So you don't wait for the patient, or you don't ask the patient if you feel something in your leg. The only thing he will feel in the leg after putting the local anesthetic and after feeling after the completion of the block. So we have here a picture of how we do the radiofrequency lumbar sympathectomy. And as you can see here that we have L2 at the lower board, the anterolateral aspect of the vertebral body at L2, junction between upper 1/3, lower 2/3, upper 2/3, lower 1/3, I'm sorry. L3 between the upper 1/3, lower 2/3. L4 usually at the middle, but all they have to reach to the anterolateral aspect, and you have to push away from the psoas. You stimulate 50 hertz at 1 volt, deep abdominal or deep back ache. Nothing in the leg. At 2 volts, no motor response. Make sure that nothing is running in the leg, or you might be inside the psoas, and the psoas is harboring the lumbar sympathetic, the lumbar plexus. The lesion, single lesion at 80 Celsius, 90 seconds for each lesion, and then rotate the needle. If it is a curved needle, rotate it once cranial and once caudal. Large lesion is important, so we use the curved needle. It makes it easier to place. Post-sympathetic neuralgia is less than the chemical. Use bupivacaine and steroids before you take your needle out, because this reduces neuritis that can take place. Well, the evidence, we have a good study here in 1991, which talks about the percutaneous lumbar sympathetic, a comparison between radiofrequency denervation versus phenol neurolysis, and they found a good outcome in patients who had post-sympathectomy using radiofrequency. The neuralgia was very low at the radiofrequency group, and after 8 weeks, the neuralgia was higher in the phenol group versus the radiofrequency group. And also another study in 2008, they found a conclusion based on a pilot study, radiofrequency lumbar sympathectomy may be comparable to phenol lumbar sympathectomy, and a large trial is recommended. This is another trial which was done in 2008 also, and they found a good outcome in doing the radiofrequency lumbar sympathectomy versus phenol also. Our protocol in our unit is we do a radiofrequency in order to reduce the chemical neurolysis outcome, bad outcome. We use a 10 millimeter curved active tip needle, 15 centimeters in length, and we stimulate 50 hertz up to 1 volt and 2 hertz up to 3 volts to make sure that we don't have any motor stimulation down the leg. And we put 5 ml, 1 ml of lidocaine plus 2 milligrams of dexamethasone before we do the lesion. And we do 2 lesions, 80 Celsius, 90 seconds, and then we advance the needle a little bit more, just 0.5 centimeters, which is 5 millimeters, and we do another 2 lesions. And sometimes we put 1 ml of phenol, just 1 ml of phenol at L3 and L4. We don't put it at L2 in order to avoid the genitofemoral nerve. And this, we leave it to the end of the procedure. If the patient gets a good response, we don't put a phenol. If the patient is still not feeling the good response after the radiofrequency and the warmth didn't get the good outcome, then we put sometimes 1 ml of phenol. And this is, we do it only on L3 and L4. So we combine both of them. This is a picture of one of the cases that we have done. And as you can see here, the needle at L4 is running the anterolateral aspect of the vertebral body. Here is L2 and L3, and we get a good response with a good linear spread, and just the contrast is hugging the vertebral body. This is another also 2008. They've said that they combine the use of radiofrequency together with 1 to 2 ml of alcohol. They don't use phenol in this study, and this is the Journal of Pain Research, evaluation of combined radiofrequency and chemical blockade of multisegmental lumbar sympathetic ganglion in painful diabetic peripheral neuropathy. So in diabetic peripheral neuropathy, we get a good outcome also. Lastly, and this is the outcome of this picture, will give you a clue about at 3 months, as you can see here, at 3 months, here is the chemical group, which is the square. At 3 months, the VAS score started to rise. In the radiofrequency group, which is the diamond, the VAS was 3 at 3 months, while in the chemical started at 3 months to reach to 4 in the patients. So we get sometimes rise in the visual analog scale after the block in such patients. Lastly, if we combine both, you will get a visual analog scale at 3 months, 2. At 6 months, 2 also. And this also at 1 year. So the combination could help in giving a good outcome if you combine the radiofrequency with the chemical neurolysis. This is a movie which we have done before in one of our patients. This patient was a manual labor that using his leg. هو اللي بنقول عليه مكواجي رجل، يعني هو كان بيستعمل رجله أكتر في الكوي يعني، فكانت بيستعمل رجله الشمال. And he came to us with suffering from that bad pain in the leg, and the neurosurgery referred the case to us. And we did for him a lumbar sympathectomy in such a way that we did the diagnostic block first and contrast at L2 and L3 and then an L4. And then we didn't do a neurolysis. We just performed a local anesthetic and steroids, and we left the patient to ambulate and to do physiotherapy. The patient with a single diagnostic block, it was in the same time therapeutic, and the patient had a good outcome and he was moving the leg at the end of the procedure, as you can see. And after 1 hour from the injection, this patient was stepping on his feet and started to walk. The edema was there, but he was able to walk after 1 hour with less pain and without the shaking technique, the shaking movement. So the take-home message, I would like to say that lumbar sympathetic block has been advocated for sympathetic mediated neuropathic pain. Controlled studies have reported a trend that sympathetic sympathectomy is effective. Modifying radiofrequency technique leads to sympatholysis comparable to 6% phenol with less incidence of post-sympathetic neuralgia. Understanding anatomical variation of the lumbar sympathetic chain is important. Radiofrequency help in stimulation and in precise decision of the location of the lumbar sympathetic ganglions. Radiofrequency better to be performed at the 3 levels, L2 and L3 and L4. Combining radiofrequency with low volume of neurolytic is promising and needs more studies. Thank you very much for your patience, and I hope I wasn't boring. Thank you.